Welcome back. Let's go over the answers to the warm-up review. First question, where do neurons of the lateral corticospinal tract synapse prior to exiting the spinal cord to affect movement? At the cell body of the anterior horn. Next question, what drugs and endogenous hormones regulate the secretion of gastric acid? Let's start with the hormones. Several hormones and chemicals promote gastric acid secretion, including histamine, acetylcholine from the vagus nerve, as well as gastrin. And then several other hormones and transmitters inhibit gastric acid secretion, including prostaglandins, somatostatin, secretin, and GIP, or gastric inhibitory peptide. And then the drugs that regulate secretion are the PPIs, the H2 blockers, and the anti-muscarinic drugs such as atropine. Now let's move on to the lecture.
In this video, we're going to discuss atherosclerosis, and we'll start a discussion of atherosclerotic cardiovascular disease that's going to span several videos, including things like acute coronary syndromes and myocardial infarction, which are covered elsewhere. But in this video, we're going to review some definitions and pathophysiology. So let's start with arteriosclerosis, which is a generic umbrella term for hardening or stiffening of the arteries, in which the arterial wall becomes fibrotic and thickened and less elastic. Sclerosis means scarring, so this is scarring and thickening of the arteries. There are several different types of arteriosclerosis. There's something called medial calcific sclerosis, or Monckeberg arteriosclerosis, which is fairly uncommon. This is a disease of the elderly population that causes calcification of the media of the arteries, hence the name medial calcific sclerosis. So the arteries become stiff and non-compliant, especially in the extremities. But the intima is not involved, so there's no stenosis and no obstruction of blood flow. This is usually fairly benign. The next type is arteriolosclerosis, which is much more common. So this affects arterioles and small arteries. And you can either see hyaline thickening of the vessel walls or hyperplasia of the vascular smooth muscle cells that gives the arterioles an onion skin appearance under the microscope. And both of these can be secondary to hypertension, which is why hypertension is such a bad disease. It causes small vessel disease long before there are any symptoms. So even without significant hyperlipidemia, patients may have arteriolosclerosis. And then the most common form of arteriosclerosis is atherosclerosis, which is the classic disease where you get the fibrous cholesterol plaques and atheromas that form in the intima of the large and medium-sized arteries. So don't confuse arteriosclerosis and atherosclerosis. They're not exactly the same thing. Arteriosclerosis is a general term describing hardening of the arteries. Atherosclerosis is just one type of arteriosclerosis, but it is the most common type. So what are the risk factors that increase your chances of developing atherosclerosis? Well, it's things like hypertension, hyperlipidemia, especially elevated LDL cholesterol, diabetes, and of course, smoking. And don't forget things like family history, advancing age, and even sex. Atherosclerosis is more common in men and postmenopausal women than it is in premenopausal women. So let's look in the study guide and review the pathogenesis of atherosclerosis. There's a progression of events that leads to atherosclerosis. It all starts with endothelial dysfunction. The endothelium is the inner lining of the arterial wall, and over time, those traditional risk factors like smoking, diabetes, and hypertension cause damage to the endothelial cells, which leads to increased vascular permeability, leukocyte adhesion, and thrombosis. Next, you get accumulation of lipoproteins. That endothelial dysfunction allows lipids, especially LDL, to begin to accumulate in the intima of the vessel and become oxidized. The next step is monocyte adhesion to the endothelium. So monocytes migrate into the intima and then transform into macrophages that phagocytose the LDL. And we call those macrophages full of LDL foam cells. The next step is labeled as factor release. So inflammation plays a huge role in the pathogenesis of atherosclerosis. So activated platelets and macrophages are releasing a lot of inflammatory mediators and cytokines. Atherosclerosis and inflammation kind of go hand in hand. And as a result of this inflammation, we see a proliferation of smooth muscle cells and a deposition of extracellular matrix composed of elastin and collagen. Smooth muscle cells are normally found in the media of arteries, but now we see the migration of these smooth muscle cells into the intima. And there's continued accumulation of lipid both extracellularly and also intracellularly within the macrophages and smooth muscle cells. And all this smooth muscle proliferation and extracellular matrix and lipid accumulation results in a bulging atherosclerotic plaque that can protrude into the lumen of the vessel and cause stenosis and narrowing and reduced blood flow. And if this plaque ruptures, that's going to trigger platelet aggregation and thrombosis, which results in an acute ischemic event, like an MI or a stroke or an ischemic limb. We said that atherosclerosis affects large and medium-sized arteries, but it doesn't affect all arteries equally. For instance, the abdominal aorta is one of the most common sites of atherosclerosis. But because it's such a large diameter vessel, it's uncommon to get stenosis or narrowing of the aorta that's bad enough to impair blood flow. What we do see in the abdominal aorta is an abdominal aortic aneurysm, also known as a AAA. AAAs are caused by atherosclerotic plaque that compresses the underlying media, and this compromises diffusion of both nutrients and waste products. And over time, this results in degeneration and necrosis of the media, leading to weakness in the aortic arterial wall, and that results in a focal dilation or bulge in the aorta, which is the aneurysm. Now, AAAs are more common in men over 50 and especially in smokers. AAA can present as a pulsating mass in the abdomen if the patient's thin. In overweight or obese patients, you might not be able to feel it at all. The bad news is that a AAA can rupture and hemorrhage into the abdomen, which can be fatal very rapidly. It can also cause embolization of pieces of atheroma, or possibly obstruction of a branch vessel and impingement on an adjacent structure, such as a ureter. You can diagnose a AAA with an ultrasound, and then we monitor the AAA with serial ultrasounds every 6 months. Now, when the AAA gets to 5.5 centimeters in diameter in men, or 5 centimeters in women, that's when you repair these surgically. You'd also repair these if they're enlarging rapidly. So if you see an increase of 0.5 centimeters within 6 months, or 1 centimeter within 1 year, then you're going to send that patient for surgical repair. Another important site of atherosclerotic disease is the coronary arteries. So let's review the anatomy of the coronary arteries. Being able to identify coronary arteries on an angiogram is about a 3-star topic. There are 2 coronary arteries that come off the aorta, the left main coronary artery and the right coronary artery, or the RCA. So it's the left main and the RCA. The left main gives rise to the left anterior descending branch and the circumflex branch, so the LAD and the circ. The LAD is the artery that's most commonly affected by an MI. You can get an MI from occluding any of the coronary arteries, but the LAD is the most common one. The left anterior descending artery supplies the anterior wall of the left ventricle, and also the anterior portion of the interventricular septum. So if the LAD is occluded, that's an anterior wall MI. Then the other big branch off the left main is the circumflex artery, which makes a hard left and wraps around the heart to supply the lateral wall of the left ventricle. So occlusion of the circumflex artery will cause a lateral wall MI. Then the main branch of the RCA to know about is the posterior descending artery, or the PDA. So the posterior descending artery goes down the back of the heart. It descends posteriorly, and it supplies the inferior wall of the left ventricle. So if the PDA is occluded, that's an inferior wall MI. Now, around 70 to 85% of people have the PDA coming from the right coronary artery, and we call this a right dominant heart. Around 10% of people have a PDA that comes off the circumflex, and we call that a left dominant heart, since the circumflex is part of the left coronary system. There's also something called a codominant heart, where the PDA is supplied by both the RCA and the circ, and that's also around 10%. The exact numbers aren't that important, but the vast majority of people have right dominant hearts. It's also worth mentioning that the sinoatrial node and the atrioventricular node are usually supplied by a branch from the right coronary artery. So an RCA infarct can affect the SA node and cause bradycardia, or it can affect the AV node and cause an AV node block. You should also remember that the coronary arteries fill with blood during diastole, whereas the systemic arteries fill during systole. Remember, the coronary arteries come off the proximal aorta, just beyond the aortic valve. So when the aortic valve is open during systole, the valve leaflets kind of open up and shut off those coronary arteries in a sense. So the coronaries fill with blood when the aortic valve is closed during diastole. Now let's talk about ischemic heart disease. Ischemic heart disease occurs when myocardial oxygen demand is greater than the myocardial oxygen supply, and it's most commonly caused by atherosclerosis. And when this occurs, it typically causes chest pain that we call angina. The typical symptoms of angina include chest pain, which is normally retrosternal chest pain, meaning it occurs just posterior to the sternum. And this can be described as pain, but sometimes people will say it isn't really a pain, it's more like a pressure in the chest or a sensation of tightness or heaviness. This pain can radiate to the neck, the jaw, or the left shoulder, and it might be associated with shortness of breath, diaphoresis or sweating, or simply some fatigue, especially in women. Female patients commonly have atypical angina symptoms rather than the classic retrosternal chest pressure radiating to the jaw. So you have to have a high level of suspicion. Angina tends to occur when there's coronary artery stenosis of at least 75%. The coronaries can dilate as needed in order to provide additional myocardial perfusion during times of increased oxygen demand, like exercise or tachycardia from fear or stress. But once the coronary arteries become narrowed more than 75%, you may start to see some problems. There are also different types of angina, or different patterns of anginal pain. Stable angina is the most common type. Stable angina is predictable. Every time the patient climbs 3 flights of stairs, or walks more than 2 blocks, or pushes the lawnmower more than 15 minutes, he starts having chest pain. So it's a stable, predictable pattern brought on by a certain level of activity. The other predictable thing is that this chest pain resolves with rest. And you may see some ECG changes with stable angina, such as ST segment depression or elevation. Next is unstable angina. So unstable angina is the same pain presentation, but now the pain is increased in frequency or it's become unpredictable. For instance, if the patient normally has angina after climbing 3 flights of stairs, but now he's having that same anginal chest pain after climbing only 1 flight, that's now considered unstable angina. It's also considered unstable angina if the pain occurs at rest, or if there's an increase in the duration or severity of the pain compared to previous episodes of chest pain. An unstable angina is generally thought to be due to transient thrombosis of a narrowing coronary artery. So that atherosclerotic plaque ruptures and it thromboses, but not bad enough to cause complete occlusion and infarction. So there's some ischemia, but there's no infarction. But you can still see some ECG changes. Then another type of angina is called Prinzmetal angina or variant angina. Now, Prinzmetal angina is not due to atherosclerotic plaques. Prinzmetal angina is due to coronary artery vasospasm. So the coronaries spasm, they narrow down, and that causes some myocardial ischemia. Because this is due to coronary artery spasm, the pain is not brought on by exertion, but rather it occurs at rest. It's generally more common in younger individuals because there's really no atherosclerosis to speak of. And again, you can see ECG changes such as ST segment elevation. Now, how do we treat Prinzmetal angina? Well, we typically use dihydropyridine calcium channel blockers like nifedipine. These drugs are going to relax the coronary arteries and block that spasm. And then, of course, myocardial infarction is the most severe form of ischemic heart disease, but we're going to cover that in another video. So we've talked about ischemia and angina due to atherosclerosis, and we've alluded to myocardial infarction as a cause of chest pain, but not all chest pain is due to myocardial ischemia. The trick is figuring out which patients have chest pain from heart disease and which ones have chest pain from something else. So knowing the differential for chest pain can be really important clinically. There are 5 big things that you need to consider and look for because these are potentially life-threatening. And we've seen a couple of them already. One mnemonic for the 5 deadly causes of acute chest pain is if you're dumped, you're heartbroken. So the D in dumped is for aortic dissection, which is where there's a small tear in the intima of the thoracic aorta and then blood forces its way into that tear and then between the layers of the aorta. This typically presents as a tearing chest pain that radiates through to the back, and you might see some widening of the mediastinum on chest x-ray. The U is for unstable angina, which we just covered. The M is for myocardial infarction. And then there are a couple of these deadly causes of chest pain that are associated with pulmonary pathology. The P is for pulmonary embolism, and the T is for tension pneumothorax, which is where there's a collapsed lung with a flap that acts like a one-way valve, so that when the patient breathes in, air escapes the lung and goes into the pleural cavity, and that kind of builds up pressure inside the pleural cavity. This is going to shift the mediastinum away from the pneumothorax, and that patient may have hypotension and hemodynamic collapse. But thankfully, most patients with acute chest pain will not have one of these life-threatening diagnoses. While in practice, it's often tricky to make the correct diagnosis based on just very quick history. On your exam, they're generally going to give you some classic clues to point you in the right direction. So let's take a look at some of these classic scenarios. ST segment elevation only during brief episodes of chest pain without exertion. This is a classic scenario of Prinzmetal angina. The patient can point to a specific painful spot on the chest with one finger. It's most likely musculoskeletal chest pain, such as costochondritis, or maybe a pulled chest wall muscle. Costochondritis is basically inflammation where the ribs insert into the sternum, usually in the upper sternum at the junction with the second rib. That's a very common cause of chest pain, and we treat that with NSAIDs. The next bullet says chest wall tenderness on palpation. This is another classic feature of musculoskeletal chest pain. Cardiac pain typically won't cause chest wall tenderness, but musculoskeletal pathology can. Rapid onset of sharp or tearing chest pain that radiates to the scapula is an aortic dissection. Rapid onset of sharp pain in a 20-year-old that's associated with dyspnea. This is a classic presentation of a spontaneous pneumothorax. It's a little different than a tension pneumothorax. But this can be very painful and causes some shortness of breath, but you don't get a buildup of pressure that causes that shift of the mediastinum. The next one is occurs after heavy meals and improves with antacids. That's classically GERD, gastroesophageal reflux disease, but it could also be esophageal spasm. Spasm of the esophagus is tricky because it isn't always associated with meals. And if you give the patient nitroglycerin, like you would for a suspected MI or angina, nitroglycerin is a smooth muscle relaxer, so it's also going to relieve the pain of esophageal spasm. So just because the patient's chest pain got better with nitroglycerin, that doesn't prove that this is true cardiac chest pain. The next one says, sharp chest pain lasting hours to days that's somewhat relieved by sitting up and leaning forward. That's classic for pericarditis. Pain that's made worse by deep breathing and or motion. That should make you think of pleurisy, inflammation of the pleura, such as from pneumonia. Or it could make you think of musculoskeletal pain because deep breathing expands the chest wall and those inflamed muscles and ribs can hurt. And then chest pain in a dermatomal distribution would be herpes zoster or shingles. And usually you'll see a rash with herpes zoster in that dermatomal distribution. The rash consists of grouped vesicles or small blisters on a red base. And with zoster, pain is a common presenting symptom even before the rash develops, sometimes days before the rash develops. And then finally, the most common cause of non-cardiac chest pain is probably musculoskeletal chest pain. GERD is certainly common too, but musculoskeletal pain is about twice as common. Now it's time for the end of session quiz. So pause the video and answer those questions, then restart the video and we'll go over the answers together. First question. A 68-year-old man has an abdominal ultrasound to check on the status of his known abdominal aortic aneurysm. His last ultrasound 6 months ago showed a maximum dilation of 4.5 centimeters. This most recent ultrasound reveals that the AAA has enlarged to 5.1 centimeters. He's asymptomatic, so what's the most appropriate next step in the management of this patient? Well, the absolute cutoff for elective repair of an asymptomatic AAA in men is 5.5 centimeters, so he's not there yet. But this patient's aneurysm increased in diameter by 0.6 centimeters within a 6-month period. So any increase of greater than 0.5 centimeters in 6 months or 1 centimeter over the course of a year would be an indication for repair. So the next step is surgical repair of this AAA. Next, a patient with poorly managed hypertension has acute, sharp substernal pain that radiates to the back and progresses over a few hours, followed by death within a few hours. So what's the most likely diagnosis? Well, this is an aortic dissection, which incidentally is not the same as an abdominal aortic aneurysm. Next, what's the most likely cause of chest pain in each of the following scenarios? So acute onset dyspnea, tachycardia, and confusion in a hospitalized patient is a pulmonary embolus. This can present with or without chest pain. Rapid onset of sharp chest pain in a 20-year-old and associated with dyspnea is a spontaneous pneumothorax. Chest pain that began 1 day after starting an intensive new exercise program would be musculoskeletal chest pain. ST segment elevation that occurs only during brief episodes of chest pain is a classic scenario of Prinzmetal angina. And then sharp pain lasting hours to days and is somewhat relieved by sitting forward is pericarditis. And chest wall tenderness on palpation is musculoskeletal chest pain. And that's it for now. I'll see you next time.
Oh no, it's...
That's right. I'm coronary heart disease. It's the leading cause of death in the United States.
But haven't you been on a steady decline since the 1960s due to advances in drugs for hyperlipidemia?
You silly human. I still kill 50% of people over the age of 65. My risk factors include smoking, hypertension, low HDL, and family history of premature CHD and age over 45.
No! What can I do? I know I will take a statin to decrease LDL, improve coronary endothelial function, inhibit platelet thrombus formation, and for its anti-inflammatory properties.
Dude, it was horrible acting. Gosh, you're not even trying.
It doesn't matter if my acting sucked, as long as we retain the information.
I am stomping and roaring my butt off over here to get ready for this exam, and you don't even care. You know what? I can't take this. I'm going in my trailer.
Come on, Sativa.